thank you to the previous speakers for setting up the topic I'm going to talk about now, which is my kind of major research aim, which is the question is so we think blood transfusion might be not cost effective. We think anemia may be bad for you. But does reversing anemia with blood transfusion improve outcome? And that's the question, isn't it? Because that's the decision that we make every day. These are my conflicts of interest. I'm going to show you a lot of pre-publication research, which is the product of a lot of work, which is done by all these people, for whom I am very grateful. And this is the study that I did several years ago, and this is our narrative, the narrative that, there's two kinds of people. There's the blood is good people, there's the blood is bad people. And this suits my narrative, which is blood is bad, because there's a career in it for an academic who wants to do research. And basically what you see is that transfusion, after adjustment for differences in baseline factors and various confounders, there is this strong independent association with increased mortality, and that it's associated with an increase in cost. But there's this great disparity between levels of evidence that tells us whether transfusion is harmful or not. Because if you look at the blue studies here, these are all the seminal observational studies which show that, and this is a forest plot. I like forest plots because they're very visually intuitive. I use them all the time, so you'll see lots of them. So this is the line of no effect. Anything on this side says transfusion is bad. Anything on this side says transfusion is good. Anything where the confidence intervals cross the line means that it's not, you're not sure. And basically the blue studies all seem to show that transfusion is bad, but the red studies do not. And the red studies are a higher level of clinical evidence. So you've got this kind of conflicting evidence about the role of transfusion for the reversal of anemia. I don't think any of us doubt the benefits of giving transfusion for people who are bleeding to death. What we're really talking about is the reversal of anemia. And I think if you look at critical care studies and cardiac surgery studies, 80% of all the blood we give is actually for anemia. It's not for bleeding. So how do we tell whether or not this data, all this evidence that's telling us blood is bad, is actually true? And is it a causal effect or is it confounding? And I'll review some of the research studies from experimental models of transfusion. We look at the strengths and weaknesses of the observational data and the randomized controlled trials. But in a way, this question about is transfusion good for you or bad for you is slightly incorrect. And actually, in fact, the real question is when do you give blood? At what point in a patient's journey do you make a decision, yes, giving blood is good? And most of the evidence we have so far doesn't even address that. But that's the key question, isn't it? Because that's the decision. We're standing at the patient's bedside and we go, I'll give him blood. I think I'm doing the right thing. But we need to have evidence to support that decision. And again, the narrative that blood is bad is very strong. This is some of the slides that I actually showed you before. The storage lesion, they get depleted of high-energy phosphates. They get this kind of spicule formation as they release, the membranes break down, they release microparticles, and then you get these kind of star-shaped actinocytes which don't really transfer blood very well. And then there's this seminal paper from Colleen Koch from the Cleveland Clinic where they showed that giving older blood to cardiac surgery patients is associated with much worse outcomes than giving younger blood. And again, this is observational, so it's not causal, it's only an association. And when we give blood transfusion experimentally, they do everything that we want them to do. They cause inflammation, they cause organ injury, and we're looking now at what the pathogenesis of that might be, and this is some work we're doing whereby we can give pigs blood, which is either day 1 or day 14, and it causes the sustained reversal of anemia in our model. But you get this funny thing where you get this blunting of platelet aggregation despite the formation of platelet aggregates. PAC1 is the platelet activating complex, which is expressed in activated platelets. And you also get the expression of these pro-inflammatory ligands on platelets. So you have a mechanism now. These changes that you see in platelets are almost identical to the changes that you see with platelets after cardiopulmonary bypass. You get the formation of aggregates, you get impaired aggregation despite this activation, and you get this expression of pro-inflammatory ligands. So you get this kind of non-specific activation of platelets by blood transfusion. And then when you give it to animals, you can see that the older the blood is, the more injury you cause. It causes activation of all sorts of endothelial markers. It causes increase in macrophages. Platelets and monocytes become more prominent in lungs and these arrows indicate kind of markers of lung injury. And you have these animal models, you give blood, you get lung injury. That's all well and good. We all think blood is bad. Then we look for parallels in clinical studies, and this is an individual patient meta-analysis of 230 patients who have gone previous studies of the Bristol Heart Institute, where I took all the data from the cytokine and inflammatory response analyses and did a post hoc analysis comparing transfused and non-transfused patients. and you do lots of fancy statistical analysis, and you get, again, this forest plot which shows that you get a systemic inflammatory response attributable to blood. Now, it's associated with blood. It's not caused by blood. But you can also do experimental tests where you give blood to platelets in the test tube, and it also causes activation of platelets. So again, the narrative that blood is bad. The evidence is almost overwhelming. This is a slide from a book chapter that is shortly to be published, and basically we do a systematic review. We summarize all the observational data, all the observational studies that seem to that have evaluated the association between transfusion and adverse outcome, in this case mortality, and you can see that the forest plot shows that if you sum this up, you've got a 2.73-fold increase in death in transfused versus non-transfused patients. All good. All good. Is it the answer, though? Probably not, and thank God for that, because then there would be no more research studies to do. Moving on, we look at infection. It tells the same story, but when we begin to look at the data a bit more closely, we see that it's not all correct, because if you look at the heterogeneity of these studies, they're very significant. We have to ask ourselves, what's the source of heterogeneity? Why can it have a very big effect in one study and not a big effect in another? And that means there are differences in the study, there are differences in the population, but it means there are things that we don't understand in this relationship that we haven't adjusted for. So, for example, when we look at whether or not there may be publication bias in these studies, we show that there's massive publication bias. So you do a funnel plot. These studies, if there was no publication bias, if they were randomly distributed about the mean effect, you should see these dots should be on either side, but you see that all these studies uniformly only show that transfusion is harmful. And this is because if you send a study in 10,000 patients to circulation saying that blood is not harmful, it's not beneficial, it's not harmful, it just won't get published because it's not used, you can't get it published. So there's bias in the data. So you only see the bad story, don't you? It's like reading the news media. And then we look at the heterogeneity in the study. So we split the data into whether or not you get small volume, medium volume, or large volume transfusions. You see this dose effect. Now, we all accept that there is this risk with massive transfusion. You see it in front of you in the clinic. You give a big blood transfusion, patients get multiple organ failure. But what this implies is what we call a regression bias, where in actual fact, these patients here are not the same as these patients here, but we incorporate them all into one big analysis. Now, we try and adjust for that, surprisingly using regression analysis, but can never totally adjust for the fact that they're just different patients. They're not the same patients, and that's regression bias that we see in these studies. The other thing is that when you have a significant population where they have an 8-fold or a 9-fold increase, it's very, very difficult for any form of analysis to extract that massive effect out of these analyses to give you the true effect. And I would highlight to you that the actual effect shown in this for infection for small units of blood for these studies, and they have their other limitations as well, don't forget, is 1.73, which is not as big as most of the studies would suggest. Finally, we look at unmeasured confounders. And Axel highlighted the triad of the three variables that can affect transfusion and transfusion-associated morbidity, and they are anemia, bleeding, and as we've shown, the volume of transfusion. And if you look at all the observational studies, 90% of them don't adjust for even these three basic confounders. So in actual fact, major confounders in these studies are often not included. And when you do a very complicated analysis, and this is from ours where we adjusted, this data has been adjusted for preoperative anemia and bleeding. We also stratified it according to the volume of blood, and we also stratified it according to the nadir hematocrit for the patient's hospital stay. And we see that actually when we're giving small volumes of blood to people who are very anemic with a crit of less than 21, it's not that bad for you after all. Another very important point is that if you think that we were looking at our effect size even for 1 to 2 units on average before at 1.7, when we look at what the triggers we may use in a future randomized controlled trial, which is say a hematocrit of 27 versus a hematocrit of 21, the power of the study that we want to detect is not the difference between 1 and 1.7. It's the difference between 1.2 and 1.05. So in actual fact, if you're going to design a study, because it will be done in low-risk patients who have low volumes of transfusion, it needs to be powered to detect a difference in effect size of something like 15%. So you need massive studies to really determine whether or not transfusion is harmful. Then the fly in the ointment. We did this animal study. We thought what we'll do is we'll display synergy between transfusion and cardiopulmonary bypass in our animal study. bypass will be bad for you, we'll give blood, it'll be very bad for you. And you can imagine my horror when I found that actually transfusion resuscitates pigs on bypass and reverses acute kidney injury. So that's absolutely banjaxed everything. So basically you put them on bypass and they get this reduction, this is baseline, this is at 24 hours, they get this significant reduction in their creatinine clearance, which is our universal measure of kidney function, which we use to define acute kidney injury. And you get this nice kind of, you get platelets, microaggregates in the glomeruli, monocytes, depletion of enos, all well and good. You give just red cells, they do the same thing, all well and good. Microaggregates, monocytes, depletion of enos, it's all there, but when you give red cells to anemic pigs on bypass, it reverses acute kidney injury. Why does it do that? Well, it probably does what it's supposed to do. It does what it says on the lid, it improves perfusion. What we know is that these red cells were 42 days old. I mean, they were garbage. You saw the pictures that actually showed you, they were just basically soup. But it didn't matter what you did, as long as you improved the viscosity of the blood, even with bad red cells, it resuscitated the pigs. And this tells us a little bit about what effect blood has, because you give blood, we all know it improves the blood pressure, probably because it chelates nitric oxide and causes vasoconstriction, but it improves your perfusion. So in actual fact, in severely anemic people, it may be good for you. On cardiopulmonary bypass, it may be good for you. And here we looked at SCOT, and what we showed is the pigs on bypass became centrally very desaturated, but when we reversed their anemia with the red cell transfusion, it prevented central desaturation and prevented acute kidney injury. So transfusion may not be bad for you all the time. When we looked at a study, we did a separate study of 338 patients, and we looked at those who'd been transfused. We stratified them according to what their baseline SVO2 had been. We saw that patients who were centrally desaturated showed an improvement in their central venous sats, implying that maybe we actually did resuscitate patients by giving them blood in this study on bypass. There are difficulties with the mathematics in this. This is me doing the mathematics, and you'll find that in fact, I think if you want to look at a nova of differences between percentages, you have to do the inverse cosine root, I think. Because there's a relationship, because the proportional difference in something at 83% is different from the proportional differences of something like that. So this is not strictly valid, but this is what I've done because it was easy, and there's lots of other studies have now shown the same thing. Marco Ranucci has published something very similar. So moving on, that transfusion may be bad and some people may be good in others. The only way really to determine which patients to give blood transfusion to is a randomized controlled trial. This is a systematic review that we have done recently of all the randomized controlled trials. There's another one here that's in another figure that have looked at the effect of more liberal transfusion versus more restrictive transfusion. And at complete odds with our observational data, it shows absolutely no causal relationship between transfusion and adverse outcome whatsoever. What does that mean? Well, when we look at the data, it's all done in low-risk patients who have low volumes of transfusion. The studies, by and large, are very low quality. They're unblinded, and I'm going to come to that in a minute, because that is really important in transfusion research, really important. Very, very limited reporting of how well people complied with the transfusion protocols. We don't actually know whether or not people just made up how they give the blood. There's no documentation of it. And again, they only showed these very small differences in transfusion volume administered, which we have shown probably doesn't have any effect whatsoever. If we look at a recent one, and this is published very recently, and this is done by Dean Ferguson, primary author of the Bartlett study, Hebert, the guy who wrote the TRICK study, which is the seminal blood transfusion paper. And you would think these guys know what they're about. So they did a study looking at 2 transfusion thresholds in a pilot in Toronto. And they showed that they had non-compliance with their transfusion thresholds of 30 to 40% because people weren't blinded. They could game, they could give patients, they could give an extra unit here or not give an extra unit here. And basically they could do what they wanted, breaching transfusion thresholds a little bit, but enough to completely confound the study. If you look at compliance, it was reasonable in theatre, it was pretty dire in the ICU, but on the ward it was 11%. So these guys who produced probably the seminal transfusion papers in the last 15 years can't do it. It's an indicator of how difficult it is to do this kind of research. The other thing to point is actually that the differences in transfusion volume are very, very small. And again, this is a feature of what we call performance bias. It's where people know what group you're in, and they can game whether or not they'll say, oh, he's a bit anemic, he's just reached the threshold, oh, we'll wait an hour, see if he goes back up above the threshold again, we'll not give a unit of blood, I don't agree with blood, and so on. The TRACS trial is the one that was published in JAMA in 2010. Again, there were certain limitations in this study. they didn't really report what their compliance was. They said their reported non-adherence rate was 0.8%. Now, if the guy who did BART and the guy who did TRIC get a compliance rate of 60%, and someone says they've done the same study and they've got a compliance rate of 99.2%, all my alarm bells go off, especially when they define what compliance was as a single line. Hematocrit concentration remained above or at the threshold for 95% of the time. That's not good enough. It's not good enough. If you look at the difference between the two groups, the difference in hemoglobin doesn't reflect the difference between the two thresholds. The thresholds were 8 and 10. If you're giving 1 unit every time you reach a threshold, the patient should then have had hemoglobins of 9 and 11. But they didn't. They had hemoglobins of 9 and 10.5, which means that they probably gave slightly more blood to some of the more anemic patients and slightly less blood to some of the less anemic patients, which is what we call performance bias. Again, you see a very, very small difference in the mean volume of unit blood transfused, less than a single unit. Was this study going to be able to detect a difference in outcomes attributable to transfusion? No, absolutely not. And this is the best study that's been done. Anyway, we got the study. It's funded by the NHR. Barney Rees is a clinical trialist in Bristol. He's the chief investigator. I'm the clinical lead. And we've tried to deal with most of these limitations. So basically, we're comparing 9 and 7.5. These are thresholds designed by a committee. It's because you can't get a big 16, 17 center study with a hemoglobin threshold of 10, a hemoglobin threshold of 6, because people won't buy into it. What we got, the thresholds we have, they'd be better if they were further apart, but then we probably would never have got the study done. Our outcomes are any serious infectious or ischemic events in the first 3 months, and we are including all patients, because we don't really want low-risk patients who have low volume transfusions. We want aortic surgery, congenital surgery. We want complex surgery where we actually can test this intervention in the patients in which it's relevant. And there is variability around the thresholds, but we just have to document what that is. It's recruiting across 16 sites. We recruited almost 1,400 patients. And one of the other things that we did is that we didn't randomize patients preoperatively. This is testing a postoperative intervention, and you only actually randomize patients postoperatively. So although you obtain consent preoperatively, patients who don't breach the 9 threshold are not randomized. That's almost 45% of the patients. So we've actually consented almost 2,500 patients. This is the biggest study that's ever been done in UK cardiac surgery, by the way. And we have these 2 thresholds. And when we look at our adherence rates, this is old data. It was for a DMEC report. When we look at our non-adherence, it's 32%. Oh my God, we think. What's the point in doing the study with non-compliance of 32%? But actually, that's any non-adherence. Our severe non-adherence rate is 7%. And that's okay. It'd be better if it wasn't 7%. And that's where someone's supposed to get blood and they don't get blood, or someone's not supposed to get blood and they do get blood. Any other compliance is whether or not someone has checked their blood twice more to see if their hemoglobin stays low before they get blood, or whether the low threshold hasn't been seen for a certain number of hours. So there's lots of different ways of defining what lack of compliance is. But this is the first study to really, really document how compliant people are, because it's the key, because performance bias has confounded every other study that's been done so far. What can the randomized controlled trials tell us? With all the limitations we said, well, they can't tell us that transfusion is harmful. All they can really show to us is that probably moderate anemia post-cardiac surgery is probably safe. It's probably safe to tolerate hemoglobins of 8. You may say, well, we knew that anyway, but did we really? We thought we did, but we probably didn't. Moving on then. This is from the Koch paper. This is the dose response curve for units versus blood transfusion. Existing randomized controlled trials have been done here. It's unsurprising they show no difference in outcome. But this is where blood transfusion affects our patients. Bleeding patients and coagulopathic patients. And this is where blood conservation and blood management improves outcome. And this is the key. Improving and preventing massive blood transfusion, large volume blood transfusion, saves lives. That's the point I want to make in this talk, because it leads on to the rest of the day, which deals with specific blood conservation interventions and the diagnosis and management of coagulopathy. Resternotomy, massive increase in resource utilization and mortality. Massive variation in resternotomy rates for hemorrhage in the UK. This is Ben Bridgewater's data from the CCAD database. People can say, oh, but we've got much more complicated patients in wherever, that's why they bleed. But actually not, because if you plot their resternotomy rate per unit by cabbage versus non-cabbage, it follows a straight line. It just shows institutional bias, institutional practice. You show that it's a volume relationship. It's absolutely not, because when you do a funnel plot, you see that there are some patients that perform very badly, and there's some patients, institutions that perform very well. So there's a lot of variability in blood management and how we manage these patients, because you do a great operation, they get very coagulopathic, you give them 5 units of blood, 2 FFP and 4 crown, they get renal failure, lung injury, and they die. And those are patients whose lives you can save with good blood management. That's what I believe anyway. So actually, as described that, I'm not going to talk about that now, because that's what the rest of the day is about. But there is this, patient blood management is a team. I don't like the term patient blood management. I prefer this term blood management. Patient blood management is a little bit too, I don't know, it's like a jingle, it's like blood management is what we do. Patient blood management is a concept. Okay, final thing about risk scores. There's lots of risk scores, but they're not very good. The reason they're not very good is because they're all being developed in single institutions. So what we've shown is that blood management across the UK is incredibly variable. So you have a risk model that's developed in Bristol. It's absolutely no use in Oxford or wherever, because our blood management is different. And what you need is, you want to be able to have a risk score that will accurately identify these groups of patients and tell you that maybe you should be giving tranexamic acid and cell salvage here, but maybe you should be giving a protein and FFP and platelets here. And this is what you need. You need risk scores that are developed in multi-centre cohorts and validated in multi-centre cohorts. We have a Bristol risk score. It's got very high diagnostic accuracy or predictive accuracy, but I bet it's absolutely useless everywhere else. And that's the key to, I think, focusing blood management in the correct patients in the future. So to summarise then, clinical experimental evidence suggests that transfusion causes platelet activation and systemic inflammatory response, and that transfusion is associated with the reversal of oxygen supply dependency and severe anemia. Observational studies overestimate the risks attributable to transfusion due to unmeasured confounders, regression, and publication bias, although there is likely a limited risk attributable to small volume transfusions. Observational studies do not inform clinical transfusion decision-making, i.e. when to give a transfusion. Randomized trials, the existing randomized trials, are unlikely to detect a causal relationship between transfusion and adverse outcome because of their low power, selection performance, and detection bias. They are, however, a useful guide to clinical decision-making, and it's the best evidence we have that restricted transfusion practice is safe. And I would follow that large volume transfusion is likely to be a major contributor to adverse outcomes. The frequency of severe coagulopathic hemorrhage is highly variable in the UK. It implies wide variability in blood management, and these patients should be the focus of quality improvement. Thank you very much.
We've got time for a couple of quick questions. We're about 10 minutes over, but any questions?
Gavin, it's Ravi from Samson. Thank you. Do you think the reason we violate all these protocols is that as clinicians we just lack equipoise and we just can't convince ourselves that it's safe to run patients anemic?
Yes, transfusion is a theology. Okay, and I define theology as a system of beliefs for which there is no evidence. Okay, so basically, some people, all my aortic cases have to have a hemoglobin greater than 10. Or, for example, me going, hemoglobin is 7.6, my threshold is 7.5, I won't be having it. And it's just a system of beliefs. There's absolutely no evidence. And when you look at the evidence, it's awful. I mean, that's no one else has looked at the evidence as correctly as we have for transfusion, and it's awful. So I don't know why anyone else holds these strong beliefs, because I have no idea. I've read all the books and stuff. I have no idea.
Two things. One attempt to defend the term patient, Axel Hoffman, Curtin University, Perth, to defend the term patient blood management. That was because traditionally the term blood management was connotated with the inventory management and the blood banking system. Yeah. And so we thought patient blood management as opposed to donor blood management. That was the cause to differentiate. The other thing is, when it comes to the design of future randomized controlled trials, it would be very interesting to look at patient blood management, like preempting the cause of blood loss by fixing the anemic patient prior to surgery, versus transfusion, so that we do RCTs where we go head to head with the two strategies. Have you ever thought about this as a next step?
No, and you're right. The whole point of calling it patient blood management is to focus it on the patient, not to focus it on the blood. And I think my suspicion about patient blood management is because it's a concept. It's no more true to say patient blood management is true than it is to say that blood transfusion is harmful. So I'll give you an example for what you just said. So for example, you would reverse anemia in a patient with erythropoietin. Okay. There's no randomized control trial, high quality randomized control trial of erythropoietin in any setting that has not shown that it doesn't increase thromboembolic complications.
That's why I said the second.
Yeah. So for example, in ITU patients, it increases thromboembolic complications in high quality multi-center randomized control trials, although it reduces mortality in some patient subgroups. If, for example, you look at the recent Kevin Karkouti study where they gave red cell transfusions to reverse anemia, absolutely not a whisper of difference. So patient blood management, it's right, it's correct as a concept. But for me, what's the reality? When I look at a patient, I go, what's my patient blood management decision? I go, am I going to give it a unit of blood? Am I going to give it FFP? That's blood management. You know, I know I'm splitting hairs, and I don't disagree with patient blood management. I think what it is it's simply a hypothesis to be tested. Because erythropoietin, I tell you, if you want to give erythropoietin to 1,000 patients who are about to go undergo cardiac surgery, you're going to have cardiac deaths because it's a known, you give it to renal patients, it doesn't benefit them in any way, but it increases thromboembolic deaths. You give it to ITU patients, you give it to trauma patients. I think you just have to be careful about saying it's the truth. I think you just have to be open to testing it. And I think that's the next big study, to my mind, it's the next big study.
Gavin Heyman-Lucas from Wolverhampton. Quick question. I'm very fascinated by your finding on your transfused pigs on bypass. Did you look at the level of the kidney protective effect for various level of hematocrit on bypass?
No, I mean, basically you put pigs on bypass, they get very anemic. I mean, they have hemoglobins of... Pigs are quite anemic anyway. They have hemoglobins of 10. You put them on bypass, they get hemoglobins of 7. And it's a model of extracorporeal circulation and anemia.
So you don't know whether you lose that effect if somebody has a hemoglobin of 9 and you give them a transfusion or 2 while they're on bypass?
No, I mean, I simply don't know the answer to your question. From the clinical study, we found that it wasn't related to the hemoglobin. The differential effect of the transfusion was not related to the hemoglobin. It was related to their central venous oxygen saturations. The thing about central venous oxygen saturations, they're very non-specific as to what they reflect about regional tissue oxygenation. So the question is whether we should be using these cytoscans or some other form of regional, which you're doing. I know you're doing the cytoscan, aren't you? That's why you're asking the question. So you want to have a measure of regional tissue oxygenation, don't you? Which, using that evidence, you might be able to use as an indicator for blood transfusion.